Hi, it's Shelly, and I'm going to do a quick video on the IV access. You can also read it in your book. But just quickly, we do IV access for numerous reasons: for giving fluids, for giving IV medications, some blood products, TPN, a lot of IV medications like diuretics, or if you're going to be giving medications for a patient that's unstable, a lot of those, most of those medications are IV. And there's different types of IV catheters. We're going to talk in the beginning about just your peripheral inserted IV, and then we're going to also talk about more of your central lines. So, question: central venous access device provided access for fluids, medication, blood products, TPN, and for hemodynamic monitoring and sampling? True, that's what a central line does. Vein site selection. So there's many reasons why we select veins when we're going to put in a peripheral line. We look at types of solutions, what kind of medications they're getting. Is it going to be very toxic? So then we're going to want to use a more bigger IV catheter. Conditions of the vein: don't use a vein if it's bruised, swollen, or recently used. Duration of the therapy, cannula size, and then the patient's age. Again, if you're going to be using therapy for a long period of time, you want to make sure you're using a bigger vein. And then your cannula size, always use the smallest as possible. And then patient's age, because elderly can have fragile veins. You want to look at activity. You're not going to want to place peripheral in the antecubital, especially if they're going to be moving around or bending their arm, because they're going to spend the entire time not being able to receive that IV fluid or IV medication because your pump will be alarming. If there's any presence of disease, a graft, a shunt, mastectomy, if there's a mastectomy on this side, you would avoid this arm. If they have a graft for dialysis, you want to avoid that arm. And definitely avoid the arm if it's got the PICC line in it. IV sites too. So people have used a jugular vein here, up here. People have also used the lower extremities like the feet. Those are for emergencies only. There's a danger of PEs, stagnant blood, and varicosities, susceptible to trauma. So the CDC guidelines recommend that all cannulas inserted into lower extremities be removed as soon as an alternative site can be established. So we do like the larger, fuller medial cubital, the cephalic veins most frequently are used, but we also will access these hand veins, and then we will also a lot of times do a lot of venipunctures through the hands. Tourniquet. So what you would do to put an IV in: you find your vein, you put in the tourniquet 2 to 8 inches above it. You can also put it right on a shirt if it's too painful. You keep the tourniquet tight enough to descend without occluding the arterial flow. And then you, if you can't see distension of a vein after putting on the tourniquet, there's a bunch of things you can do. You can compress edema away from the site. You can pat or rub in one direction and let gravity work for you. Put that arm lower. You can have them squeeze a ball. And then also, if you don't see a vein, then just apply heat for 15 minutes and come back. Before putting in a IV catheter, you want to cleanse your hands, put on gloves and mask, identify the vein, scrub the skin with some ChloraPrep, make sure it's nice and clean, and then with the bevel up, you're gonna inject the needle in, and then you're gonna, once you get blood flow back, you're gonna retract the needle, leaving only the cannula in, and that technique, you're at about 10 to 30 degrees angle when inserting in the IV. And then after that, I call it the 4Ts. You're going to release the tourniquet, apply the Tegaderm. You're going to attach the extension tubing, and then you're going to tape that extension tubing, not under the Tegaderm, over the Tegaderm. So that's your 4Ts: tourniquet, Tegaderm, tubing, and tape after IV access. And then you're going to document the date of insertion, the gauge of the catheter, the length, site of the placement, and then your initials. You'll do it on the catheter itself as well as in your chart. You're going to want to document the site for assessment every 4 hours, 4 to 6 hours, depending on your hospital policy. Changing IVs used to be at a set schedule, but now we are just doing it. Basically, if an IV is placed in the ED or outside the hospital, we want to change them as soon as possible, or with at least no longer than 24 hours. And then all other IVs, we're just basically now assessing for signs and symptoms of infiltration or phlebitis, and if they look good, we're continuing to use them. But again, you're going to have to go by your hospital policy. Complications. Oh, first we'll just talk about, look at all these central lines. There's tons of central lines. So if you know a patient has a central line, figure out what they have, where it's placed, where it's going, where the tip of the catheter is, and just make sure you always remember that IV lines, those can be changed under clean technique, but if you're going to be doing an IV catheter, a central IV catheter dressing change, this is under sterile technique. These catheters tips are going right into your SVC and some right into your right atrium. So we want to make sure that we are keeping that site clean. Aseptic technique when preparing and administering fluids and medications. Okay, so this is infection. You can see that at the tip, it's got some maybe a little pus coming out. It's red. So you can see local cellulitis. And then here's your phlebitis. So your phlebitis is when you have some kind, basically your vein intima is inflamed. There's pain and tenderness at the catheter site and along the course of the vein, erythema at the catheter site. There can be inflammation and swelling with a feeling of warmth. So that is your phlebitis. And then you have infiltration. That's when the needle went through the vein and then your solution is basically leaking in, not inside your vein, outside your vein, and it's into the tissue. You want to stop immediately. You want to remove the catheter, elevate the limb, and then assess and document the appearance of the site. Extravasation, this is when there's a toxic material that basically is, same thing here. It goes into the surrounding tissue, but the medicine is a vesicant, and it can cause extravasation, and they grade them based on level of severity. 1 and 2 do not require extensive intervention to prevent long-term skin and soft tissue damage. 3 and 4 have a potential for skin necrosis, compartment syndrome, or future plastic surgery. And just some things. So there's a bruising, infection, there's an extravasation. Kid looks like he might lose his foot. I can't see the filtration. Phlebitis, and then extravasation plus 10 days. I couldn't find really good extravasations out there, but if it is a vesicant, you want to stop giving medications right away, but leave the IV in place. If it's a non-vesicant, you just want to remove the IV. And again, if in the beginning, if you're learning the differences between vesicant and non-vesicant, I would just ask somebody. I stopped my calcium chloride from being infused. It infused into the tissue. What is the next step? And then kind of work together. That's just some practical pearls there. But we grade phlebitis on a scale of 1 to 10. We grade extravasation on a scale of 1 to 10. I mean, excuse me, I keep saying 1 to 10. 1 to 4. This is from 1 to 4. This is from 1 to 4. But again, these are some of the scales I've seen are differ a tiny bit. But again, just know that the higher the number, the worse the problem. Phlebitis up here, prevention is to use filters if you're going to be using specific medications that can cause your vein to become irritated. Dilute meds to make sure they're not going in there so caustically. And then some promptly addressing any peripheral complications. If there's anything that, pain when you're flushing, it's swollen, which would be an infiltration, this is your phlebitis, you want to remove the peripheral immediately, except if you had one of these extravasations here with a vesicant that could cause some really bad damage. You want to call the doctor. You want to document the event in the nursing documentation. If it's a really bad extravasation, probably will need a patient safety report done on the patient. Again, that will be hospital specific and what type you do. And then document daily an examination of the affected site until that site has resolved its findings. The last, I don't have a picture of catheter embolism. It's very rare. It occurs when a piece of catheter is severed and enters the circulation. Defective catheter or sheared catheter. Um, Again, never seen it in a ever, but just make sure that all your parts are, when putting in a catheter, are, the product has integrity, that there's no broken pieces. Um, that's really it. All right, so that is IV access in a nutshell. Hope that answers some of your questions, and let me know if there's any follow-up questions. Thanks.